And welcome to the Dr. Bob Show. Did you know that 30 million people in the United States, 30 million every year, develop a stuffy nose and pressure around the sinuses with postnasal drainage, with purulent yellow or green nasal exudate? They don't feel well, they get fatigued, they get malaise. How do we treat that? And what happens if the treatment doesn't work and that sinus infection, yes, that's what we're talking about, if that sinus infection persists for 3 weeks, 6 weeks, even 3 months, the treatment changes at that time. What is the new treatment and what do we do? My guest is Dr. Mark Overholt. Dr. Mark Overholt is a board-certified ear, nose, and throat specialist. He'll be answering our questions. He deals with this every day. Hello, I'm Dr. Robert Overholt, and I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about food allergies. Did you know they could be life-threatening? Is it a food intolerance? Is it a food sensitivity? Or is it a true food allergy? We'll be discussing that. And everything you wanted to know about reflux disease, but were afraid to ask your doctor. A lot of information for you. You'll want to stay tuned. We're talking with Dr. Mark Overholt, board-certified ear, nose, and throat physician, deals with chronic sinus infections and sinus infections every day. And if you're going to look at the table here, we've got a mannequin, and we're going to be discussing later on some of the newer treatment in-office surgery for sinus infection. Brand new, wonderful treatment and advancement. A lot of information for you and I both to learn. Mark Overholt, welcome to the Dr. Bob Show.
Thanks for having me.
Tell me about sinus disease. What is sinus infection, sinusitis?
So, chronic rhinosinusitis is a complex issue, and a lot of it hinges on immunology and the person's predilection or tendency to have inflammation in the sinuses. And it can go one of two ways. It can be just primarily an immunologic inflammatory issue, or it can be an infectious issue, or it can be both. We have lots of patients, most of the ones that we see have infectious problems, and they experience swelling in their nose, recurring infections, blockage of sinus drainage pathways, and they present feeling miserable. They have chronic cough and fatigue and headache and midfacial pressure, and they just don't feel good.
So tell me about, where are the sinuses? Are there different ones? Where are they? What are they like?
So they're air-filled cavities that live in our face. They're paired. We have two frontals, and we have two ethmoid sinuses between the eyes.
What do the ethmoid sinuses look like when you look at them on X-ray or when you visualize them?
On an X-ray, they look like a honeycomb space. And
so there's several of them that are by the bridge of the nose.
Correct. They're sort of up between the eyes. And then there are maxillary or cheek sinuses, if you will, that are below the eyes in the midface. And then we have a pair that are way back in the center of the head called the sphenoid sinuses.
Why do people have sinuses?
Good question. That's one of those pearly gate questions you're going to ask someday, but it certainly takes weight away from the face, and it provides some resonance characteristics for speech, but they certainly cause a lot of misery.
So how do you know which sinus is infected, and how do you know if somebody really has a sinus infection?
History is important. So when we see patients, we take a comprehensive physical and history and physical, and we look at things like what's their allergy tendency, and how often are they becoming sick, and have they been treated appropriate with medications. And once we've passed through all that, then the real diagnostic tool is CT scan. So we use CAT scan X-rays, if you will, to look at the sinuses to tell us, is there thickening in the sinus lining, or is there an air fluid level with infectious material in the sinus?
Can you do a CT scan of the sinus in the office, or you have to send somebody and they have to come back, or they come back next week? How do you do that?
If the patient's been appropriately treated, we do them in the office immediately, and that spares patients a day in the office, another day at the x-ray department, and another day back with us to review it, so we can do everything comprehensively in one visit. Most contemporary ear, nose, and throat docs have an in-office CAT scanner now. It's a great tool.
So if somebody has a sinus infection in the frontal sinuses, can you see that on the CT scan? What's it look like?
Clearly, the frontal sinuses are typically black and air-filled, but if there's infection, that turns gray. That's just the way the CAT scan looks.
Same thing with the sphenoid?
Same thing
or with the ethmoids, I mean?
The same thing with ethmoid and maxillaries. It's the same.
And the maxillaries?
Yeah.
So how do those sinuses drain? If they're infected, you got to get rid of the infection. How do they normally drain?
There are common channels of drainage for each sinus. The frontals and the sphenoids have their own channel, but the maxillary and ethmoids drain through a common channel for the most part. And we know where those areas are, and we look for them specifically on the CT scan. One very important one is in the midface where the ethmoid and the maxillary sinuses come together. It's called the infundibulum, and that's a common area for misery for people. If that area becomes obstructed, people will improve with antibiotic therapy, but as soon as that's withdrawn, they tend to relapse back into infection. And those are the patients we start to talk about procedures to open up those blocked areas. Certainly there are people that have isolated or combined frontal sinus disease or sphenoid disease, and the same thing holds true. We look at the natural drainage pathway, we can see it on the CT scans, we'll show the patient where their problem is, and we can target it and go fix it now.
If somebody has just an acute rhino nose sinusitis sinus infection, do those usually need to be treated aggressively? How do you treat a common cold that goes with the sinuses?
A common cold, you just give decongestants, and you hope that within 7 to 10 days the patient gets better. We certainly don't want to give antibiotics for colds because then you're just selecting out bacterial resistance and the antibiotics don't work well. And so we have a real caution in the medical community today to try to avoid immediate use of antibiotics because 80% of rhinosinusitis is viral, and those don't respond to antibiotic therapy, and that goes away on its own typically.
So we have to treat that symptomatically with saltwater sprays, with decongestants, with antihistamines, stuff to loosen up the mucus, and time.
Correct.
When do you make a decision on antibiotics?
Usually 10 days out. If the patient's not getting better or if they're worsening after that first week, then it's probably time to consider an antibiotic therapy.
Do you usually, if somebody's had the problem for 2 to 3 weeks, do you usually get a CT scan at that time, or do you start off with an antibiotic?
No reason to get a CT scan at that time. There's nothing that in that patient's history, if it's just acute, that would say we're going to have surgery. So the patient that needs a CT scan is that person where you're asking the question, is there some obstruction that might require a procedure that would allow them to get better? So that's the patient that doesn't respond to antibiotic therapy after several trials of prolonged antibiotics, or the patient who's experiencing recurring episodes of sinus infection in close proximity to each other.
So if somebody has a chronic sinus infection, they haven't responded to normal treatment, to antibiotics, then you get a CT. If that shows the blocked area, the infundibulum you said, or wherever the sinuses drain into, that's a sign that you're going to have to open that area?
That's probably the case at that point.
And that's sinus surgery. Now I want to clear up one thing right here. Sinus surgery, when I first came into private practice in 1902, no, not really, but when I first came into practice in the 70s, in the early 80s, the sinus infections, the surgery, you had to pack them and they had black eyes, and it was really a very difficult problem. Does that happen now normally?
No, we're much gentler and much more targeted. And you'll see some of the tools in a few minutes that we're using now to make recovery very quick for people.
Yeah, are the new advancements in surgery and the new tools that you're going to show me and us, because I'm going to be learning too, are they easy to do? Are they effective? And do they give the patient the answer we want most of the time?
Yes, they're easy to do. They're highly effective, and if you look at outcomes, the targeted surgeries that we're doing in the office or in the OR too, those are equally effective to past procedures that were much more invasive. So we're nicer to our patients, and their outcomes are at least as good, probably better.
So you can do some of this surgery in the office.
Much of it.
And that's what we're going to be talking about when we come back. How do you do in-office sinus surgery? What's it like? You're going to be amazed. You'll want to stay tuned. We're talking with Dr. Mark Overholt, board-certified ear, nose, and throat physician. We're talking about chronic sinus infections. We're talking about sinus infections that haven't responded to treatment. That's decongestants, saltwater sprays. If no response, eventually an antibiotic, then no response. We've made a decision that we're going to have to do surgery to open up the sinuses. And that's where we are now. Mark, tell me about the endoscopic sinus surgery. What does endoscopic sinus surgery, what do you do?
Classically, the person's in the operating room asleep under anesthesia, and we take a fiber optic rigid telescope and put it in the nostril. That allows us to see the anatomy in the nose, and we know from training where the sinus openings are, and then that scope projects an image on a TV screen, and we guide our tools into the area to open up the sinuses that are blocked.
So that's pretty modern technology. You're looking at a CT scan, you've got a rigid instrument, you know where the anatomy is. What anatomy are you looking for in endoscopic sinus surgery?
Well, we talked about the infundibulum, that common opening, and we can see that classically on the side wall of the nose. There's a little ridge that it hides behind. It's behind what's called the uncinate bone, and we look at middle turbinates. There are just a number of normal structures in the nose that we use to guide us around surgery.
Do you have to remove that uncinate bone? And when you do, what does that do for the patient?
Removing the uncinate bone removes the obstruction in the infundibulum so that the sinuses begin to drain again. And that's primarily for the maxillary sinuses, again, the cheek sinuses. And then the ethmoid sinuses are, as we discussed, a honeycomb space. And so air cells within that honeycomb network will become obstructed, full of infection, and we use a special tool called a shaver or microdebrider to open or unroof those little air cells that are obstructed.
Do you have to remove them, the ethmoid sinuses?
They're removed.
So we can take out the infundibulum, the uncinate bone for the maxillary sinus, then we can shave off the ethmoid sinuses if they need it. And you use what for the frontal sinuses?
Same technology. We have special tools that allow us to access the frontal sinus. They have special curves, and but the advent of balloons in nasal surgery has changed the management of some of the sinus cavities, specifically the frontal and the sphenoids. In areas where we had trouble traversing the curves, we can now get up with a wire that's guided into the sinus area and dilate the neck of the frontal sinus. If you imagine an hourglass narrowing, you can dilate that hourglass narrowing so that the sinus drains the way it's supposed to.
So if review for the viewing audience, the frontal sinuses are right here, and the sphenoid sinus is sort of in the middle of the head.
That's correct.
Back in the head. So we're going to design where we can open those with balloon surgery in the office. Tell me about that.
Right.
What's it called first?
Well, balloon sinus surgery is, it's just another tool that we have in the armamentarium. It's still an endoscopic sinus surgery. So we use balloons in the operating room. We use them in the office. It's a fantastic tool that we have in our toolbox to help manage people that have problems. And we still use an endoscope in the operating room or in the office to be able to see the normal anatomy. But the balloons have gotten a ton better, and I'm going to show you a really neat one today that has an image guidance capability. So
image guidance.
So we'll take a CAT scan of someone's head, the same one we've used for diagnostics.
You take a CAT scan of this head.
Yep, exactly. And then we can use a computer to generate a three-dimensional model, and we can map that person's face and their sinuses with that three-dimensional model. And then in the balloons, the wire that helps us guide into the sinus cavity has a guidance tip on it, like a GPS signal that tells us where the balloon's going to end up. And we can guide that signal using some some screenshots of the CT scan, in addition to using our endoscope to be able to see the anatomy. And it's much more effective. It simplifies things for us. It cuts down on time and discomfort for the patient.
So you know the normal anatomy. You've got an instrument that will guide you, knowing the anatomy plus the CT scan that's three-dimensional, will tell you what sinus is. All of them?
It'll target the specific sinus. The CAT scan will tell us, is it frontal, is it ethmoid, is it sphenoid, is it and which side is it on? So we can guide ourselves right into that specific sinus.
So show me what you do. Let's pretend like we're at your office and I'm on the table. Are you going to give me some local anesthetic, or are you going to knock me in la la land? What are you going to do?
So we often will use oral sedation, but the anesthesia is typically topical. So we'll put some lidocaine on some cotton pledgets up in the sinus cavity, leave them there for 20 minutes to numb the nose. Occasionally we'll inject in the nose around the sinus opening just so the patient has absolutely no pain, but you don't feel that because you're already topically numb. Some guys don't even use the injection, but I think in my experience, it helps the patient have a better experience. So we numb the patient topically. We then use the endoscope to look in the nose.
Show me the endoscope again. Let's show that up to the camera there.
We don't have an endoscope. This is the balloon. But an endoscope would be a rigid camera that would look like this. It would just have a fiber optic into it, and we would stick the camera in the nose, and the camera image would be projected onto a screen, so we would be able to see all the anatomy magnified in front of us. And then we can use the balloon, which has the wire that extends from it. We use our minds and our eyes to guide, but the balloon tip also tells us when we're smart and when we're not.
So show me when you put that in the nose, show me what it looks like.
So as you look at the top left-hand side, you can see that the tip of the wire is traversing into the nose. And now it's about to go in the sinus. If I get my scope, I'd slip it right in there for you. But
so when it goes into the...
There you are. So now we're in the sphenoid sinus.
There was a little ding-ding, so the GPS instrument tells you if you're inside the sinus or not?
That's correct.
Amazing.
It is really amazing.
So now you're ready to do the opening. You're ready to put the balloon in to dilate up the blocked hole.
Correct. So now that the wire is in the sinus cavity, we'll pass the balloon with another sliding piece of equipment over the wire into the sinus cavity. Then your assistant will inflate the balloon. It's a certain size, and it will dilate the opening of the sinus. And then we take the balloon down, deflate it.
You don't leave the balloon in there.
Nope, it goes home with me.
So you dilate up the balloon, then you deflate it, pull it out, and what has it done in there?
It's opened the sinus cavity, so what was once obstructed is now open. And the beautiful thing is, if you look at studies, there's great durability to this procedure. So the patients maintain patency and openness of that sinus just as long as they would with a traditional operation, opening it with, removing the tissue around the sinus opening. So it's fabulous, and patients basically drive themselves home after this. If we give them sedation, we have somebody drive them home. But if we don't give them sedation, they can just get local anesthesia and go back to work if they want.
You can go back to work that day or the next day? Or
you could go back that day if you wanted to.
And so what we've done is we've got a blocked sinus that we've now unblocked. We've unblocked it by balloon sinuplasty or balloon surgery, and that keeps the sinus opening where it will drain for a long, long time.
Correct.
And that relieves the problem of obstruction.
And we're not cutting tissue and removing tissue, so the bleeding that was associated with traditional sinus surgery is basically alleviated with the balloon.
Do you get better results with balloon sinuplasty or the endoscopic sinus surgery that you did early?
They're both outstanding as far as results go.
That's absolutely amazing. Did you ever believe you'd be doing balloon sinus type surgery?
No.
And it must be very gratifying to be able to do this in the office where the patient doesn't have to go through the surgery and through the bleeding, etc.
We have patients that come in with pain in their frontal sinus. We'll dilate the frontal sinus and they'll leave saying the pressure is gone.
Absolutely amazing. Mark Overholt, you're a great teacher. Thanks for coming and teaching us about the newest thing in surgery, which is balloon sinuplasty sinus surgery. You've been a great teacher.
My pleasure. Thanks.
Fascinating. Know that if you've got chronic sinus disease, chronic obstructed blocked sinuses, that you most likely will be able to have balloon sinuplasty. And now you'll want to stay tuned. We're going to be talking about food allergies. They can be life-threatening, but is it really food allergy, or is it an intolerance, or is it a sensitivity? And if we have time, what can reflux disease do other than give you heartburn? A lot, and we'll be finding out what. You'll want to stay tuned. I want to thank Dr. Mark Overholt. Amazing discussion on new types of sinus surgery, balloon sinuplasty. Wow. Now for questions from you, the viewer, that I think will be important to your health. Question number one, Dr. Bob. How do I know if I have food allergies, and how dangerous is it? About 30 million people in the United States will have food allergies. 5% of children will have food allergies. The most common foods to cause allergy would be egg, wheat, milk, soy, fish, shellfish, crustaceans, shrimp and lobster, tree nuts and peanuts. All of those can cause serious allergies. The most serious would be peanut allergy. There are more deaths from peanut allergies than any other foods. The most common food allergy is milk allergy. It causes severe problems, but not as severe as peanuts. And the second most common is egg allergy. So let's talk about what are the symptoms of food allergy. Well, mild food allergy could simply be itching, a rash. It could be even a flare of eczema. It could be that you have even a little bit of stomach problems with some diarrhea. But the serious food reactions are anaphylaxis. And with anaphylaxis, we have it where the blood vessels will dilate and the blood pressure falls, and so we go into shock or almost shock or fainting or pre-fainting, and we can lose consciousness. The airway can become narrow with anaphylaxis, and we begin to wheeze because the air can't go through the air tubes. People get swelling of the lips or swelling of the eyes. They break out in hives all over. They're itching, they can't breathe, they get the urge to purge. That's true anaphylaxis, life-threatening. The treatment for that is early treatment with adrenaline, epinephrine, with an EpiPen auto-inject. Now, how do we make the diagnosis? Well, the most important way is with history. So if you take a good history, you should be able to find out if somebody is allergic to foods. If you can't find it by history, then you do allergy skin testing. And the skin testing will show a red, itchy place if somebody has a food allergy, especially to those 8 most common foods. If there are skin problems and you have to do blood work, that's RAS testing. RAS testing has a grade of 1, 2, 3, 4, 4 being the worst. Usually a grade 1 or grade 2 may not be as serious as some people think it is, but grade 3 and grade 4 can be very, very serious. If somebody has food allergies, our best treatment is avoidance. Sometimes peanut allergy will change somebody's life because just a small amount of peanut could cause a severe anaphylactic reaction. So we have to make sure that any food you eat doesn't have peanuts, or a salad hasn't had peanuts from another salad, etc. So it changes people's life, and they have to have an EpiPen with them at all times. Good news. There is new treatment to desensitize for peanut allergy. There are 2 ways that it can be done. Number 1 is by peanut flour, increasing the dose slowly day by day. It's a protective mechanism. It doesn't get rid of the peanut allergy, but it makes it where the person can make a mistake and may be able to eat 2 to 3 peanuts if they become mildly tolerant, mildly desensitized. So if they make a mistake, it may not cause the life-threatening anaphylactic reaction. It does not mean people can eat a bucket of peanuts. And so you have to understand what you're doing. There is a new patch that comes out that's got peanut in a membrane that's absorbed into the food where it goes to the immune system, and the immune system develops protection. Also, that allows us to make mistakes, but does not cure the peanut allergy. So there are new advances. Will we be able to do that for milk and for eggs and for other foods? Keep tuned, because we're getting better and better at learning how to treat food allergies. Well, that's all the time that we have for this show. I hope you've enjoyed it as much of it as I have. Remember, we need to be exercising. Make exercise a part of your life, because if you do, you'll be healthier with the exercise. Eat properly. We all know that we should be eating less and eating better types of food. Get 7.5 hours sleep. If you get that 7.5 hours of sleep, you'll feel better. The people around you will feel better. You'll make better decisions. If you're not sleeping well, talk it over with your doctor. You may even have to see a sleep specialist to make sure you have a good 7.5 hours of sleep. And most of all, what is it we like in the Dr. Bob Show? It's that laughter in your life. If you laugh a lot, you'll be healthier. Your immune system will work better. You'll be healthier. You'll be happier. And the people around you will be healthier and happy. So laugh and giggle a lot.